posted the link to the slides for this presentation in the chat box. Once the presentation has been loaded for viewing, you'll be able to find it posted there as well. The register button will change to view. So this session is being recorded and will be available approximately 3 to 5 business days from now. I will turn it over to Dr. Ulmer. Thank you very much.
Thanks. Good afternoon, everyone. This is the Behavioral and Social Sciences webinar in preparation for the CPH exam. So I'm going to start off with a definition of behavioral and social sciences in public health. Behavioral and social sciences are an approach that takes the multiple of disciplines that are part of public health and uses those disciplinary perspectives to promote health and prevent disease and death. And the actions to promote health and to prevent disease and death occur through an enhanced understanding of the determinants of health. The second way is by using evidence-based strategies that are also theoretically derived for health promotion and disease prevention. And the third way is by using systematic models for program planning and evaluation. We're going to cover 8 topics over the course of this webinar, and we'll cover the 4 that are listed on the left as part of the first part of the webinar. We'll take a 15-minute break, and then we'll cover topics 5 through 8 in part 2 of the webinar after the break. So we're going to start off in this part of the webinar talking about the pattern of disease, the social ecological model, theories of change, and health promotion and disease prevention. This slide is showing the changing pattern of disease in the United States, looking at about 100 years ago in 1900 versus the most recent data from 2010. And we're looking at number of deaths per 100,000. Again, the top graph is for 1900, the bottom graph is for 2010. And you can see the dramatic change in the pattern of disease. If you look at 1900, you see the 2 leading causes of number of deaths are pneumonia and tuberculosis, infectious diseases. You look at the 2 leading causes of death in 2010, you see heart disease and cancer. So the pattern has changed from one of infectious diseases to one of chronic diseases, which calls on different public health approaches to solving these problems. This is a picture of the global mortality pattern, and chronic disease is...
Welcome to GoToWebinar, Webinars Made Easy.
...% of deaths worldwide. If you look at the worldwide death figure, 58.8 million deaths, 35 million are accounted for by premature deaths from chronic diseases below the age of 60 or...
Welcome to GoToWebinar, Webinars Made Easy.
And you can see that cardiovascular diseases, heart disease and stroke, and cancer are the 2 leading causes of death worldwide. This is a picture of the chronic disease deaths by income group. So in this graph, we've taken the World Bank income groups, and the 4 groups are defined at the bottom of the graph. They're low, lower middle, upper middle, and high. And you can see that the majority of chronic disease deaths worldwide are occurring in either the low-income countries and the lower middle-income countries. And so many people have a false perception that chronic diseases are diseases of affluence or diseases of the Western world. And it's very important to know that the changing pattern of disease that we see in the U.S. is a changing pattern of disease that's really mirrored worldwide, where we have chronic diseases accounting for most of the deaths worldwide, and most of these deaths are occurring in lower income populations and lower income countries. Now, when we look at the pattern of disease, one of the things that we want to try and understand are what are the causes behind these leading causes of disease. And when we look at actual causes of U.S. deaths, we see that behavioral risk factors are implicated in preventable death. The behavioral risk factors, the actual causes of death, are listed on the right side of this graph, and they're in descending order in this pie chart. So tobacco is accounting for 435,000 deaths per year. This is in the U.S. And then diet and activity are accounting for 365,000 deaths per year in the U.S. Alcohol is accounting for 85,000. So behavioral risk factors, tobacco use, poor diet, physical activity, inactivity, and excess alcohol consumption are the major causes of early preventable death. I want to talk a little bit about health disparities. So when we look at the leading causes of death, when we look at heart disease, cancer, and stroke, and we see how those death rates are distributed by race, ethnicity, we see a pattern of health disparities. And I'm showing white and black for the purposes of talking about health disparities, but health disparities exist among all populations of color. So I'm just showing on the graph white and black. So for heart disease, we see a pattern of blacks having higher death rates for heart disease, for cancer, and for stroke. And this health disparities relate to poorer health outcomes for groups that experience discrimination or exclusion. And this, again, this graph is just showing black versus white rates as an illustration, but health disparities exist because of gender, because of age, because of education and income, because of geographic location, disability status, or sexual orientation. And then I want to talk also about health inequities on the next slide. Health inequities go beyond health disparities. Health disparities are talking about differences in death rates or disease among different subgroups in the population. Health inequities go one step deeper to look at the cause for health disparities. And when health disparities are due to systemic injustices, including things like residential segregation and unequal treatment in the healthcare system, the disparities are called health inequities. And these health inequities can present not only as differences in death rates or disease rates, but also as different access to different parts of the healthcare system, including access to needed medical procedures and access to quality medical care. This graph, the graphs that you see here are showing some examples of health inequities by racial ethnic status. The red bar is showing the whites, the blue bar is showing blacks. And if you look at the diagnosis graph, that's showing the percent abnormal mammograms when the follow-up time is longer than 60 days. So 60 days is the usual and customary time interval between an abnormal mammogram and when a diagnosis should happen. And 20% of the time for blacks, that interval is longer than 60 days compared to 12% for whites, showing an inequity in timely diagnosis. The graph on the right is showing the percent starting treatment within 30 days. Again, this is a usual and customary clinical interval, acceptable clinical interval between the time there is a diagnosis and when treatment should start. And for whites, the percent who start treatment within 30 days is 83%. For blacks, it's 69%, showing, again, another health inequity in accessing timely treatment. So when we see that disparities and inequities exist, what have we learned about the strategies that can be used to effectively reduce disparities? And there are 5 evidence-based strategies that work to prevent or reduce health disparities. The first strategy is to increase access to services for all through financing mechanisms. The Affordable Care Act is an example of that, Medicaid and other financing mechanisms. Organizational changes, so changing the institutions where health care is delivered in order to increase access, and removing legal and transportation barriers that get in the way of all populations, all subgroups in the population's accessing care. A second set of strategies are to design programs that are culturally competent and linguistically competent to reduce those cultural and language barriers to accessing services. A third strategy is to improve patient-provider communication so that during clinical encounters there is a free flow of information and communication that's leading to an accurate assessment, diagnosis, and treatment. The fourth strategy are programs that eliminate provider discrimination. And the fifth strategy is increasing the minority representation among the healthcare workforce. The book that's listed here is a resource if you'd like to learn more about the social determinants of health and how health inequities can be prevented or reduced through action. This is a resource from the World Health Organization Commission on Social Determinants of Health, and they've brought together in a very extensive report all of the information about health inequity on a worldwide basis, the social determinants of health, and how those determinants may be addressed through action. So I'm going to start a review of this first part of the webinar by launching a poll question that I'd like the audience to answer. So the poll question is listed, and I would ask the audience to answer, and then we'll go over the responses. Okay, it's been about a minute for this question. We've got about 59% of the votes in. I'll give it another 15 seconds or so. Okay, we've got about 63% of everyone attending voting, and the answers are 2% major infectious conditions, 96% for major chronic conditions, 2% for accidents, and the correct answer is major chronic conditions. So the group that has the highest contribution to total mortality in the U.S. currently are the major chronic conditions, and it looks like everybody got that. So thanks. I'm going to launch the second question now. This question is about the 3 leading causes of death. Let's take about a minute to answer. Okay, we've got most people voting. The correct answer for this is tobacco, diet, inactivity, and alcohol consumption. About 71% of everybody attending indicated that that was the correct answer. The other 2 answers included motor vehicle accidents, motor vehicle injuries, and that's those are a higher rate. They are one of the leading causes of death, but not the top 3 leading causes of death. Again, the top 3 leading causes of death are tobacco, diet and physical inactivity, and alcohol consumption. Okay, I'm going to stop and see if there are any questions about this first section of the webinar. There was a question from a participant about the terminology of disparities and inequities being used globally, and it is being used globally, particularly by WHO and local government agencies that are connected with WHO endeavors worldwide. There are some questions that have to do with leading causes of death by age group, and those are great questions. And the resources that I've included on the webinar will give you that additional detail of leading causes of death by age, leading causes of death by racial ethnic group, location. So what I'm trying to do is a more general pattern for the entire population, and you would just, as you were focusing on problems that you were concerned about, you would want to have that additional level of detail about breaking down the leading causes of death for populations that you were interested in. Okay, thanks for the questions, and thanks for the great work on the 2 poll questions. I'm going to move on now to the next section of the webinar. This section is going to talk through the social ecological model as a very inclusive and comprehensive framework for looking at the determinants of health problems. And having this careful framework, a very comprehensive framework of determinants of health, allows us to accurately act to prevent and control health problems, because we are looking in a comprehensive way at all of the influences that may be affecting the health problems. The social ecological model is a framework that pulls together factors across different levels, and the graph shows the different levels of the model, starting off with at the first level is the individual level, which in influences at the individual level include things like biology and genetics, and individuals' knowledge, their attitudes, their beliefs, their sense of self-efficacy, the skills and competencies they have. And so at the individual level, those are the kinds of factors that can affect health. The next level up is the interpersonal level. And at the interpersonal level, influences include factors such as role modeling, the support that we receive, tangible and intangible support we receive from others, the perception of social norms, and the perception of social norms can come through relationships with families, friends, and peers. The level above the interpersonal level is the organizational level, and these factors include things such as informal and formal organizational rules, regulations, policies, and the norms of organizations such as schools and workplaces. The level above the organizational level is the community level, and that includes factors such as relationships among organizations in the community, informal networks that exist within the community, and the perception of the norms of the community. Finally, the level that's at the most contextual is the policy level influences, and these include macro level factors such as belief systems that are religious or cultural belief systems, the norms that are considered societal norms, economic and social policies, and national, state, and local laws. So these are the different levels of the social ecological model, moving from the most micro level of individual through the most macro level of policy. And there are some characteristics of this model, how this model works, that are important to note, and they're listed over on the left of your slide. One of the characteristics of this model that's important is that multiple factors influence health behavior. So factors across these different levels can be major determinants of a particular health problem. A second characteristic of this model is that influences interact across levels. And what that means are things like factors at the community level can affect factors at the interpersonal level to then affect a health problem. So each of these levels, factors within each of these levels can directly affect a health problem, and then factors at each level can affect each other. So there can be an effect of community on interpersonal, organizational, on individual, and it's that interaction between levels or across levels that affects the health problem. The third characteristic of the social ecological model is that multi-level interventions are the most effective. So strategies that target major determinants at different levels are the ones that are most effective for preventing and reducing many of the health problems that are the current public health challenges. And finally, the last characteristic of the social ecological model is that the interventions that are designed based on these social determinants of health are most powerful when the behavior that we're addressing has been identified and defined as specifically as possible. I wanted to give you an example of using the social ecological model for a case. And so I'm picking a case that involves tobacco use, since tobacco use is the most preventable cause of chronic illness and premature death in the world. And so in this case, we want to see how far we have come with our actions to prevent and reduce tobacco use, and then explore how the social ecological model can help us improve and enhance our current strategies. So one of the things about the pattern of tobacco use, in particular cigarette smoking, is we see over time that cigarette smoking has decreased. And while it has decreased overall for most of the population, smoking rates have remained high in certain subgroups. So while we see this overall trending downward in tobacco use, which has been very encouraging, that downward trend hasn't been seen by all subgroups in the population. And in particular, smoking rates have remained high among racial and ethnic minorities, among individuals who have not graduated from high school, and from individuals living in poverty. So one of the conclusions that we can draw is that the existing strategies that we're using for tobacco prevention and tobacco control are not having the same impact and the same reach on racial and ethnic low-income groups. They seem to be having more impact on the population as a whole, but not to these subgroups. So here's where the social ecological model may help us. It may, by having a broader understanding of the determinants of tobacco use, it may help us identify additional interventions that can be used to make sure that these decreases in use are something that goes across the entire population and doesn't leave certain subgroups behind, which is shown as a health disparity or in health inequity. So this slide is showing the social ecological model of tobacco use among young low-income men attending employment training centers. And on the left side of this table, the levels of influence of the social ecological model. And on the right side of the table are a listing of the types of determinants at each of those levels. So at the individual level, we're looking at nicotine addiction, social position, tobacco-related health beliefs, psychological factors such as depression, anxiety, and future time perspective, and then comorbid substance abuse, particularly alcohol and marijuana use. Those are all occurring at the individual level of influence. At the interpersonal level of influence, we have family influences such as family member tobacco use, family approval for tobacco use, receipt of tobacco or money to purchase tobacco from family members, and availability of a place to smoke at home. Peer influences include peer tobacco use, perceived peer approval for tobacco use, and receipt of tobacco from peers. Stressors at the interpersonal level include racism, trauma, family conflict, and arrest or probation. And then coping strategies include things like the reliance on avoidance-oriented strategies, such as denial or minimization. At the organizational level, at the Employment Training Center, there is staff tobacco use, limited enforcement of tobacco restrictions, and the social advantages of smoking breaks. At the community level, structural disadvantaging, including material wealth disadvantage, differential employment opportunities, differential educational opportunities, differential political influence, and racial and residential segregation. Other community factors include easy access to tobacco, alcohol, and other drugs, the community norms around tobacco use, cultural beliefs about tobacco use, limited enforcement of tobacco and alcohol laws and regulations, and community violence. And finally, at the societal level, tobacco taxes, tobacco prices, and societal level racism. So this model, using the social ecological model, gives us additional factors to consider when we're designing tobacco prevention and control strategies that may help us prevent the health disparities and health inequities in tobacco use that we're currently seeing. So I want to now move into theories of change, and I'm going to check just for a minute to see if there are any questions about the social ecological model to answer before we move forward to theories of change. Okay, there was a question about future time perspective. That was one of the risk factors or factors at the individual level in the social ecological model. And that's a construct that's come out of psychology that looks at how much an individual looks forward to the future and anticipates having a future. And so in many groups that are experiencing disparities, who are living in disadvantaged situations, including poverty, discrimination, and racism, there is a very limited future time perspective, and there's much more focus on the moment because of not being really able to envision a long life or a productive life. Okay, there's another question about how organization, community, and societal levels differ from one another. I'm going to go back to the slide on the social ecological model. So to explain this, make sure that I differentiate these levels. At the organizational level, we're talking about organizations, and organizations are sitting in communities and they're sitting in societies. So, sorry about that. So organizations are also reflecting the context of the community that they sit in, and the community is reflecting the context of the society that the community is part of. But when we're talking about organizational factors, we're talking about those particular factors that reside within a particular organization. So an organization can be a health department or a nonprofit organization or your workplace or a school. And each of those organizations has their own rules and regulations and norms. And so those are the factors that occur in your context where you are at a particular period of time during the day. Community influences are influences in your neighborhood and in your community. And policy level influences are the societal level. So where you work or where you go to school influences your behavior. Where you live influences your behavior at the local level where you live, and where you live in terms of country, state country affects your behavior. Does that help for explaining some of the differences between those levels? Okay, there's another question about how is racism a risk on a societal level, and racism has multiple effects on individuals. Racism can be something that's experienced as part of an interpersonal relationship. And in that way, racism would be an interpersonal level influence. But when racism is more systemic as part of a society where there's structural disadvantaging that sets up that certain subgroups of the population do not have equal opportunities, in that case, racism is a societal level influence. Does that answer that question about racism as a societal risk? Okay, so thanks for those great questions. I'm going to move on now to theories of change. And let me just get to the right place in the presentation. Okay, so for theories of change, I am going to be talking about the theories divided into these three major levels. So we will be talking about three theories of change at the individual level: the health belief model, the theory of planned behavior, and the trans-theoretical model. And then at the interpersonal level, we'll be talking about social cognitive theory, social support, social network theory, stress and coping, and social influence. And then at the level of organization and community, we'll be talking about organizational change theory, community organization theory, communication theory, and diffusion of innovation. So I wanted to just make sure that I say that these are not, this is not a comprehensive, inclusive list of every single theory of change, and I'm going to point you to a resource that has information about many more theories of change at the end of this section. But these are the theories that are used most prominently in behavioral and social sciences. So that's why I'm focusing on these particular theories, and I wanted to make sure that I covered the predominant theories at each of the three levels. So these are the predominant theories for each of the three levels that we're going to be talking about today. When we're looking at theories of change that that focus on the factors within individuals, these theories are used to understand and change individual health behaviors. So changing things like tobacco use, physical inactivity, diet, alcohol consumption. These theories are used to understand why those behaviors are occurring and how to use an understanding about major risk factors in order to change those individual health behaviors. The theories of change that are at the individual level focus on factors that are within the individual and typically include factors such as beliefs, attitudes, and the individual's readiness to change. This is a diagram of the health belief model. And in the health belief model, the focus is on that what the individual believes determines how they behave. So the basic premise of this model is that a health behavior that you are interested in changing is determined by the perception of the threat of the health problem, an appraisal of the recommended behavior to prevent the problem, and cues to action. The major constructs of the health belief model, there are 6 of them. Perceived susceptibility is the belief about the chances of experiencing the risk of getting a condition or disease. So how susceptible do you think you are to getting that particular condition or disease? Perceived severity is a belief about how serious a condition is and its related consequences. So how serious is it if you would get that condition or disease? Perceived benefit is a belief in the efficacy of the action to reduce the seriousness of the impact. So the action that you would take, how strong your belief is that it would benefit you and reduce the likelihood of the condition or disease. Perceived barriers are beliefs about the tangible and psychological costs of the advised action. So what gets in the way of being able to act? Cues to action are strategies that you can take that will activate your action. So if there is an action that is being recommended that has perceived benefits, there are limited barriers, you think you're susceptible and you want to take that action, cues to actions are strategies that will help you take that action towards health. Self-efficacy is your confidence in your ability to perform the advised action. The second individual level theory is the theory of reasoned action. And in this case, we're not looking at how beliefs are related to behaviors, but we're looking at attitudes as determinants of behaviors. The basic premise of this theory is that behavioral intentions are the best predictors of behavior. And then when we want to understand how do behavioral intentions, how are they formed, how are intentions formed, the intentions are formed by attitudes about performing the behavior and beliefs about whether others who are important to you approve or disapprove about that behavior. So the major constructs in this particular theory include behavioral intention, which is the intent to enact the behavior, the attitude, which is your evaluation of the behavior, and the subjective norm, which is the perceived expectation to perform the behavior from others. And the note at the bottom is showing about the theory of planned behavior, which is very closely related to the theory of reasoned action. The theory of planned behavior is essentially the same as the theory of reasoned action, but there is one additional construct that's added to the three that we've just talked about, and that's the construct of perceived behavioral control over the performance of the behavior. And this is the third individual level theory of change. It's called the trans-theoretical model, and it is saying that individual behavior is a result of readiness to change. The basic premise is that change comes about through a process, and there are different stages of this process, and individuals are at different stages within this process in terms of their readiness to change. So the process is shown in the diagram, where you have pre-contemplation. Second stage is contemplation, where you're looking at the pros and cons of changing. The third phase is a determination, where you say you're going to carry on as before, or you make the decision that you are going to change. The fourth stage is active change, where you're putting your decision to change in place. The fifth phase is maintenance, where you've put that change in place and now you're maintaining that change over time. You're sustaining and continuing that change over time. And the sixth phase is relapse, when you've returned to the previous behavior, and at that point you need to put into place relapse prevention strategies and have an active change reinstituted and then sustained. An important part about the trans-theoretical model is that because behavior change is seen as a process, people can be at different of these stages, and based on which stage someone is at, you would intervene with stage-specific strategies. So for example, if somebody is at the contemplation stage, where they're weighing pros and cons, your strategies are directed at moving them from the contemplative stage to the determination stage, of where they make a decision about positive behavior change. If somebody's in the active change phase, your intervention strategies are directed at how do you keep that active change that they've instituted sustained in their life. So strategies differ based on what stage of change somebody is in. Okay, now I'm going to just check if there are any questions that are related on the individual level theories, the three that we've just described. There's a question about, for the individual level models, is one used more, or has it been shown that one is more effective for change? And it really depends on the particular health behavior that you're interested in. So what you should do when you're interested in a particular health behavior, whether it's immunization status or tobacco use or dietary change, you should do a review of the literature that shows you which models have been used for that particular health behavior change and what has been most effective in a research situation. So I don't want to make a general statement that one model is better than another. You're always looking for a fit between your particular health problem and the evidence about the determinants of that problem, and you want to pick a theory that matches the determinants that have been shown in the literature. And then you want to also choose a theory where there's some evidence that those strategies have been effective in preventing or reducing the problem. Okay, there was a question about decisional balance, so let me go back to, sorry. In the trans-theoretical model, one of the things that is part of the trans-theoretical model is that to move successfully from these different stages, from one stage to another, requires both decisional balance and self-efficacy. And decisional balance is this process that individuals go through at each stage where they are looking at what are the benefits to me of making this change versus the cons of making the change. So it's kind of the pros versus the cons. The cons would be what are the costs to me for making this kind of change. And so the benefits could be things like improved health status. The cons could be things like a change in a lifestyle pattern that goes against activities that are typically done as part of your family or as part of your peer group, so you're now going to be different from your family or your peers. And so this process of looking at the benefits for you versus the cost for you of a change is part of what goes into moving to the next stage. And when the decisional balance is that the benefits outweigh the cost, then you choose to move to that next stage. So when you've determined to change and you want to move to active change, you've made a decision that the benefits of the change outweigh the costs of the change. So I hope that answers that question. There's another really good question about, is it common to combine the individual models? And that is something that people do, and not just the individual models. People will combine constructs across levels as well. So you might do an intervention that is addressing factors or constructs from the interpersonal level as well as the individual level. And again, the way you choose theories is that the literature will give you the evidence base about the primary determinants, the major determinants of a particular health problem that you're interested in. And then when you look at those determinants, if those determinants are at the organizational level, the interpersonal level, and the individual level, you would want to use theories at each of those levels to guide your action to prevent or reduce that problem. So you're using theory to fit what you see as the pattern of determinants for a particular health problem. And there's not one theory that's better than another. It's a fit issue of what theories best fit the pattern of determinants that you see. Okay, I think I've answered the questions about the individual level. So I want to talk about theories of change that are focusing on relationships. So these are the interpersonal level theories. And these theories are used to both understand and change the interactions that individuals have with others that are related to health behaviors and to health status. So some of the things that are critical factors in the theories of change at the interpersonal level are things like social relationships that influence health, and the learning processes that occur as part of social relationships, the nature and the quality of the relationships between individuals, and the coping strategies to deal with the stress that comes about because of interpersonal relationships are some of the major factors of the interpersonal level of theories of change. So I'm going to talk about some of the main points about these interpersonal theories. The first one is social cognitive theory. And the focus in social cognitive theory is that learning processes are a determinant of health. The basic premise is that individuals learn both from the experiences that they have and the experiences that they witness when they see behavior and its consequences by watching others. A key part of social cognitive theory is this construct of reciprocal determinism, where the idea is that the factors that are related to the behavior, the interpersonal factors, and the behavior interact with each other such that interpersonal factors can lead to the behavior, but then the behavior in turn affects those interpersonal factors, and so that you have this reciprocal circular process. They interact as determinants of one another. The second interpersonal theory is social support, social network theory, and this is a focus on the nature, number, quality of relationships between the individual and other individuals that they connect with in the different environments that they're part of, and the nature of the relationships that the individual has with those in their network influences what they believe and influences their behaviors. For stress and coping theory, the focus is on coping strategies as a determinant of health. The basic premise here is that stressful experiences are constructed as an interaction between the person and the environment that they're sitting in. The external stressor from the environment is mediated by how the individual looks at that stressor, and their appraisal of that stressor, the nature of that stressor, their perception of what that stressor means, and also their appraisal of the resources that they have available to be able to respond and manage that stress. So there's an external stress, and in stress and coping theory, the individual appraises that stress and appraises all of the resources they have to either prevent or manage that stress, and they utilize those strategies to cope with the stress and reduce it. In social influence theory, social influence is a process that's directed at behavior change primarily through communication, and the communication can be either through a formal relationship or an informal relationship. Social influence can happen. An example of a formal relationship is doctor-patient or teacher-student. an informal relationship where social influence can happen are interpersonal relationships. An example would be parent-child or friends, one friend to another. The behavior change under social influence theory occurs through interactions, and the interactions can be with others who are similar. So you're more likely to change your behavior when you see that behavior change in somebody who is similar to you. The behavior change may also be more likely to happen when the other person who is showing that changed behavior is somebody that you highly value. So it can be somebody who has a lot of appeal either to you personally or somebody who is esteemed and valued society-wide. Another time that social influence, you're influenced by the behavior of another. So you can be influenced by behavior of another who is similar to you, somebody who you value highly, and the third case is when that other who has the different behavior, the changed behavior, you would consider to be an expert. So those are the way that social influences happen most often, again, through a formal or informal relationship, and you're more likely to change your behavior when the other person is similar, valued, or expert. Okay, I'm going to check on questions in this area of the interpersonal theories. Okay, a couple of really good questions. Thank you. There's a question about explaining reciprocal determinism, and so that's in social cognitive theory. And in reciprocal determinism, you're looking at determining factors about you're learning about situations, and you're changing your behavior based on what you have experienced or what you witness. And those factors affect your behavior. But then how you behave affects those factors. Because we're at the interpersonal level, we're looking at a relationship between an individual and others. And so when a parent rewards a child for good behavior, that child's good behavior then reinforces the parent. So reciprocal determinism is that the factor affects the behavior affects the factor. You see this a lot in violence research, where you look at a parent using physical discipline strategies for child misbehavior. And it's described as the escalating cycle of violence, where if the parent uses physical discipline strategies for the child gets more aggressive. The child getting more aggressive makes the parent more aggressive with their physical discipline strategies, and you see this escalating cycle of physical violence within families. So that's an example of reciprocal determinism. It's not just a one relationship that the interpersonal factor to the behavior, but the behavior comes back around and can change that interpersonal factor. There's another great question about how is social network different from social influence. So social network has to do with kind of the size and who is in your network. So somebody who has very few people that they're connected with has a limited social network. You might have limited social network and those relationships are all positive, so that's the quality of your network is a positive quality, but it's just limited in size. But you can also have a limited social network and have those relationships be negative, in which case you have very few people you're connected with, and those connections have a negative connotation. So network has to do with the number of people you are connected with and the quality of those relationships. Social influence has to do with an other that may be somebody you have a personal relationship with, and it can be formal or informal. That person's behavior influences your own. So in the social influence model, we're talking about a doctor giving information about behavior change and that influencing a patient's behavior. And that would be through a formal relationship where the doctor is considered an expert. A friend can decide to change their diet by substituting water for sugar-sweetened beverages. So that's an informal social influence that is because of somebody being similar or somebody who's highly valued. So I hope that helps with the distinction between social network and social influence. Okay, thanks for the questions. Really, really appreciate it. And I did want to say that because of the constraints of time, I can't get to every single question, but I will go through all of the questions after the webinar is over and make sure that I provide answers that can be posted online at the time that the webinar is posted. Okay, so I'm going to talk about theories of change that are at the level of organizations and communities. And these theories of change help us understand and change the role that organizations and communities play in either supporting or getting in the way of behavior change. And they focus on factors in organizations and communities such as policies and practices, community organization and community building, the production and exchange of information, and how widely disseminated innovations are. The first one that I'm going to talk about is organizational change theory. It is focused on organizational policies and practices as determinants of health. And there are two different approaches that are part of the basic premises of this theory. One is the stage approach and the second is the development approach. In the stage approach, the premise is that organizations go through different stages as they embark on a particular change process. And the stages are similar to the stages of change that we saw when we looked at the trans-theoretical model. So you initially have the organization initially has an awareness of a problem, then they initiate action to solve the problem, and then they have to sustain or maintain those changes that they've made. In the developmental approach, the focus is on factors that are related to organizational functioning, and those factors need to be identified and then changed. So when an organization is not functioning effectively, that can affect the health of the employees of the organization, and those factors, organizational functioning factors, need to be changed. In community organization theory, the focus is on community organization and community building, and that when communities are well organized and have been developed, have been fully developed, then those communities are healthier communities for individuals to live in. The basic premise is that community groups, community coalitions identify problems. They then identify the resources and mobilize resources that they have to solve those problems, and they design and implement a strategy to reach the common community goals for health. Communication theory is focused on producing and exchanging information as a determinant of health. And the basic premise is to use media and communications to provide information and to influence behavior change. The last theory in this area is diffusion of innovation. Its focus is on the widespread dissemination of successful innovations. And the idea about this is that an innovation has been found to work for a group in the population, and you now want to diffuse this intervention across a wider area, across a wider geographic area, across different age groups, etc. And so in this process of dissemination, you look at issues concerning how you communicate about the innovation. You look at the uptake of the innovation by a target population, and then you look at sustained use of the innovation and looking at institutionalization of that behavior. And all of those factors, uptake, regular use, and sustainability and institutionalization, are part of this process of diffusing an effective intervention across a wider area or wider group. Okay, so here is a case that will just help us play with the theories that we've heard about just for a little bit. So I want you to think back about the theories that we've talked about at the individual level, interpersonal level, and community organizational level. And this is a case where you're designing a tobacco cessation program for college students, and you're doing that as part of a campus initiative to go smoke-free for the entire campus. And you're using different theoretical frameworks to develop your intervention component. So as we talked about, you can, based on the evidence about what the major determinants are, you can then use constructs from theories at different levels that match those major determinants of the problem that you're interested in. So we're going to use theoretical frameworks that are coming from different levels to develop our intervention component. And what I want you to do is raise your hand on the attendee panel if you agree with each statement. So there are going to be two statements. We'll start with the first one. So statement number one, a very well-known and highly respected young artist endorses quitting tobacco use on a local radio program, which is popular with art college students on that campus. Do you agree that this is an example of the theory of planned behavior? Raise your hand if you agree. Okay, I'm looking across our attendees, And the correct answer would be disagree, because theory of planned behavior looks at intentions and attitudes as determinants of behavior. And the key factor here in this intervention is that you're using a well-known and highly respected young artist to influence the behavior of college students. So the best fit of this intervention with a theory would be social influence theory. So let's try the second one. Again, you're going to try and match the theory that fits the best with the strategy. So in this case, you're developing brief steps to quitting wallet card. Do you agree that this is an example of the health belief model? Raise your hand if you agree. Okay, it looks like about 20% of you agree with that statement, and the correct answer is to agree. It fits best with the cues to action in the health belief model. So in the health belief model, you're trying to influence the beliefs about a problem to change a behavior, and cues to action help you engage in that behavior. So in this case, if you're trying to help people reduce or cease their use of tobacco, some strategies that are like brief steps to quitting that they can carry around with them and that they see on a routine basis serve as cues to action as part of the health belief model. So I'm going to check if there are any questions about that little case scenario that we just had. Okay, thanks for that. And I just wanted to encourage all of you. I think one of the difficult things about differentiating between the different levels of theory and then within a level distinguishing among the predominant theories that are part of that level is, trying to understand how they are different from one another and when is the best situation to apply a certain theory. So one of the things that I think would be helpful for you to do is to, over the next couple of weeks, try to pick a program that you're working on or that you're interested in or familiar with, and then try to identify constructs from the theories of change that you think are the basis of the program that you're either working on or familiar with. And that might be a good way to play a little bit more with the theories and understand how they are different from each other. And then I had mentioned to you that the theories that I've covered are the major theories that are used across the 3 different levels, but there are many more theories of change that have been used in behavioral and social sciences research. And this resource is a a free resource on health promotion practice that is a very comprehensive look at the different theories, and it does a nice summary of many different theories along with diagrams and applications, and I think this is a good thing to use if you want to refresh about the theories that we've talked about today, as well as refresh about other theories that are important for behavioral and social sciences. And it can be downloaded from the link that's there on that page. Okay, so I want to talk now in this section about health promotion and disease prevention. This is the last section that we're going to do before break. First of all, to distinguish between health promotion and disease prevention. Promotion, these definitions are from the World Health Organization. And for promotion, we're talking about enabling people to increase control over their health and the determinants of their health. Health promotion activities focus on changing individual knowledge, attitude, and skills, as well as enacting laws and policies and regulations that address air and water quality, housing, food supply, income, and working conditions. So this is a very comprehensive definition about strategies that are directed at wellness and promoting health and well-being. For prevention, the definition is approaches and activities aimed at reducing the likelihood that a disease or disorder will affect an individual. And it's also approaches that will interrupt or slow the progress of a disorder or reduce disability. So we might prevent a disease from ever happening, we might slow its progress, or we might result the disability consequences of that particular disorder. And any of those activities, either the prevention, slowing progress, or reducing disability, are part of prevention, disease prevention. This is a very nice framework from CDC for public health action. It's called the CDC Health Impact Pyramid, and it has created this triangle that reflects the impact of factors at different types of factors. And so the factors at the top of the pyramid have the smallest impact on population health. The factors at the base of this triangle or pyramid have the largest impact on population health. So counseling and education does not have as large an impact as things towards the bottom, like changing the environmental context and socioeconomic factors. And over on the right, I've given examples of the types of strategies that would be at each of the steps of this pyramid. So for counseling and education, counseling about eating healthy or being physically active would be an example of a strategy that would be from the top of the pyramid and would have a relatively smaller impact than things that are lower down in the pyramid. Clinical interventions are one step lower down. Examples of that are prescriptions for high blood pressure, high cholesterol, and diabetes. In the middle of the pyramid, we have long-lasting protective interventions. Those are things like immunizations, brief intervention, cessation treatment, colonoscopy. For changing the context, this is in changing the environmental context that people live in. Again, we're moving towards larger impact on the population strategies, things like fluoridation, removing trans fats from food sources, smoke-free laws, tobacco taxes. Those all change the context that individuals live in and have larger impacts than the other interventions near the top of the pyramid. And finally, at the bottom of the pyramid, socioeconomic factors including poverty, education, housing, and inequality changing those has the potential to have the largest impact on population health. I want to talk some about prevention that's based on a disease continuum. So as we think about a disease that hasn't emerged yet and then progresses along, we have strategies that can be delivered at each part of the disease continuum. So at the very start, over on the left, are primary prevention strategies. Primary prevention strategies are delivered before the disease has emerged, and the goal of these strategies are to prevent the disease from ever occurring. So an example of primary prevention would be immunization. Other examples include safe drinking water, monitoring the food system to make sure that food is safe, adequate diet and physical activity, preventing youth access to tobacco, sunscreen, protective clothing, workplace safety regulations, airbags. Those are all examples of strategies that prevent the occurrence of disease or injury. Secondary prevention strategies are delivered at the next point in the continuum. So this is when the disease is at its earliest stage. So we're not trying to prevent the disease from occurring, but we're trying to identify and detect disease, early disease, quickly and promptly in order to be able to provide treatment. So examples of secondary prevention include screening for cancer, screening for heart disease and diabetes, screening for lead exposure, screening for TB, screening for HIV, screening for mental illness, and substance use. And then finally, when the individual has the disease, we have strategies put in place that are directed at limiting the disability, consequences, complications, severity, or progression of the disease. So examples of tertiary prevention will be things like retinal exams for diabetic retinopathy. So you're trying to, the person has diabetes, but you're trying to prevent the visual complications of diabetes by having retinal exams every 6 months for diabetics. Stroke and post-heart attack rehabilitation programs, cancer survival programs, hospice programs are all examples of tertiary prevention strategies. In general, the primary prevention strategies and the secondary prevention strategies are considered prevention services, and the tertiary prevention strategies, which are trying to limit disability, complications, severity, and progression, are clinical services. Prevention activities can be also targeted to different groups in the population. So the previous slide was talking about how prevention activities come into different parts of the disease continuum. This is how prevention activities can be organized based on different groups in the population. And the three terms are universal interventions, selective interventions, and indicated interventions. Universal interventions are designed to be received by everyone in the population. Selected interventions are directed towards subgroups in the population who have specific risk factors. And indicated interventions are strategies designed to reverse in individuals a pathogenic sequence. So we move from universal, which is everyone in the population, selected to at-risk subgroups, and indicated, directed at individuals. I want to mention the importance of evidence-based prevention programs and policies. It's very important to know that there are established resources for identifying prevention programs and policies that work. And a couple of the resources that we have our U.S. national resources, and it's called the Community Guide. The Task Force on Community Preventive Services is an independent group that's affiliated with CDC, and the task force produces the Community Guide. The people on the task force, along with the staff at CDC, look at the evidence base about different interventions. And for a particular health problem, they will rank the interventions as being evidence-based, promising, no evidence, not enough evidence, or deleterious. So it's a very good resource for being able to look at a health problem and see which preventive strategies have an evidence base to work to change that particular problem. And I've included the link for the Community Guide for you on this slide. These are some examples, again, drawn from the Community Guide, just to give you an illustration of the types of strategies. So these are evidence-based strategies, and I took the major risk factors of preventable death that we discussed earlier. Tobacco use, physical inactivity, poor diet, and alcohol misuse. And from the Community Guide, these are the evidence-based strategies that work for these major risk factors. For smoking, it's smoking cessation programs, school-based prevention curricula, minor access laws, that's restricting minors from purchasing tobacco before the age of 18, cigarette excise taxes, and smoke-free environments, so all the clean air laws. For physical activity, it's moderate amounts of low-intensity physical activity, accessible stairwells and sidewalks, safe neighborhoods, and affordable facilities for exercise. For healthy diet, it's including more fruits and vegetables, increasing grains and fiber-rich foods, decreasing total fat and saturated fat, decreasing salt and sugar, having restaurants encourage healthy eating habits, and having food manufacturers lower the fat content of processed food. For controlling alcohol misuse, alcohol reduction programs, school-based prevention curricula, reducing access to minors, alcohol taxes, and supervision in alcohol risk work environments like bars and nightclubs. For community health practice, the steps that we go through in order to implement evidence-based strategies are to start with identifying the stakeholders for a community health change, mobilizing the community for that change, assessing the needs and all of the health factors and determinants of health at the community level to get basic information about what the community needs are and the challenges and resources at the community level. And then community-based participatory research, which takes the information from the community assessment and is a collaborative approach that involves community members in looking at that information to identify and implement solutions and also evaluate the outcomes. The resource that's shown on the right of this slide is a very nice free resource from CDC that can be used for community assessment. It includes public access data that's at the local level on social determinants of health, a very comprehensive set of social determinants of health. So if you wanted to do a community assessment, you could go to this directory to identify existing data sets that would help with your community assessment. And I'm going to launch 2 more poll questions that will help us with a review of what we've covered in this last section of this part of the webinar. So this question is, in the CDC Health Impact Pyramid, fluoridation and smoke-free laws are examples of. Okay, it looks like most people have voted, and the votes are split between long-lasting protective interventions and changing the context. And the correct answer is changing the context. Fluoridation and smoke-free laws change the environment that individuals sit in. So they are the best fit for changing the context. Examples of long-lasting protective interventions would be things like immunization and colonoscopy. So they are efforts directed at individuals but that have a long-lasting effect. I'm going to check if there are questions about that. Okay, I'm going to now launch the next poll question. Okay. Screening is an example of. Okay, it looks like most of you have voted and have gotten the answer correct, that screening is an example of secondary prevention. Secondary prevention, again, is directed at the earliest stages of disease to detect disease and treat it as early as possible. So we are going to take a 15-minute break. Let's come back at 3 o'clock. And that's 3 o'clock Eastern Time. So we'll be back in about 15 minutes and we'll start part 2 of the webinar. Welcome back to the second half of the Behavioral and Social Sciences webinar. Hope everybody had a good break. During the second part of the webinar, we're going to be talking about the 4 issues that are listed on the right side of the slide. So we're going to start off with talking about an overview of some of the major ethical issues that are involved in program planning and evaluation. We'll talk about planning models. We'll talk about methods for evaluating programs. And then we're going to conclude with strategies for scaling up programs and promoting program sustainability. So I wanted to display a timeline of what would be the major ethical developments that led up to the Belmont Report, which is the underpinning of all of our research with human subjects. So the Belmont Report is in '79. It's the foundation for all of the work for institutional review boards and for promoting the principles for research. And our timeline of what led up to the production of the Belmont Report starts in 1932 with the initiation of the Tuskegee syphilis study. We're going to talk a little bit more about the syphilis study because it has such an impact on the way that we conduct research. In '39, there were the Nazi experiments, and in '46, the Nuremberg trial concerning the Nazi experiments, which resulted in the Nuremberg Code. 2 years later, in '48, the United Nations adopted the Universal Declaration of Human Rights. In 1963, the Willowbrook study was influential in ethical issues involving human subjects research. It was a study involving hepatitis research on mentally retarded children. 1 year later, in 1964, the Helsinki Declaration. In 1972, we have the first public exposure of the Tuskegee syphilis study. So the study that started in '32, 40 years later, first is exposed in 1972. In 1974, 2 years after that public exposure, we have the first federal protection for human research participants. And then in '79, the Belmont Report promoting the principles for research with human subjects. So the Tuskegee syphilis study started in 1932, and in this study, which has also been termed a study about bad blood, which is the way it was advertised to the residents of Macon County, Alabama. In this study, the American government promised 600 men in Macon County. They were all poor, all African American men. They were offered free treatment for bad blood, which was the name for syphilis at that time in that community. 600 low-income African American men were recruited by government health workers, and they were monitored for a 40-year period. During this entire 40-year period, the men were never told about the experiment. And one of the things that is so terribly troubling about this is this study went on during this 40-year period that study was going on. It was continued for decades after effective treatment for syphilis became available. And what is even worse than this study being conducted when a treatment has already been found to be effective is that when subjects were diagnosed as having syphilis, the researchers of the study intervened to prevent them getting this effective treatment. As many as 100 men died of syphilis during the study, and when the participants died, the researchers offered their families free burial in exchange for the right to do autopsies so they could gather more data from the autopsy.
The study was reviewed throughout the 40-year period by U.S. Health Service officials, and the reason it was extended for so many years is the argument that the study was benefiting medical science. In 1966, Peter Buxton, who was the whistleblower about this study, learned about it. He was a venereal disease investigator in San Francisco, and he sent a letter to the director of the Division of Venereal Diseases where he expressed ethical concerns about this study. And so he worked within the system from 66 to 72. And in 72, when he had gotten no action about his questions about the ethics of this study, he went outside of the organization and complained about the study to a reporter with the Associated Press in San Francisco. And then July 25th, 72, the story appeared about this study, which created a landslide effect that led up to so many of the protections that we have today for research with human subjects. Following about 2 years following the publication of that article and the dissemination of the information about this study and the ethical issues involved in the syphilis study, a class action suit was brought against the federal government. It was settled out of court for $10 million in 1974. Also in 1974, at the time that the class action suit was settled, the U.S. Congress passed the National Research Act, which required that institutional review boards, or IRBs, approve all studies involving human subjects. So no human subjects research could continue until could be initiated or proceed in any way until the Institutional Review Board had gone over the plan for the research and approved the plan for the research. And then in 1997, which is more than 20 years after the report and the class action suit, there was a much delayed federal government apology when President Bill Clinton issued a formal apology for the study, and that was at the urging of the Surgeon General, his Surgeon General, David Satcher. The Belmont Report is the report that provides all the ethical principles guiding the conduct of research with human subjects. When the National Research Act was passed in '74, part of the act, in addition to setting up institutional review boards, was to create the National Commission for the Protection of Human Subjects in Research. And the Belmont Report summarizes the work, the 5-year work of that commission, going into detail about all of the ethical issues involved in human subjects research, such as what's the difference between practice or service in research, what are the basic ethical principles of respect for persons, beneficence and justice, informed consent, assessments of risk and benefits, and selection of subjects. And I've provided 2 resources for if you would like to learn more about ethical principles involved in research and the research about public health programs and research related to the delivery, implementation, and evaluation of public health programs. One is concerning the issue of deception in research, which has been a debate about, do you have to deceive subjects in order to collect accurate information? It's a really intriguing dilemma, and I think getting some more detail about it from a case can really help you understand some of the subtleties about deception in research. So this link is to the Stanford Prison Experiment, which is a very nice audio-visual about deception in research. And the second resource is a YouTube video on what it means to be a scientist, and it's a guide to responsible conduct in research. Again, a really nice video tool for exploring some of the issues about ethics in public health action. So to do a little quick review of this section, I'm going to launch another poll. Okay, it looks like most of you have voted, and nearly everyone has selected the correct answer, which is D, the Public Health Service syphilis study, where the question was about the research that most strongly influenced the 1974 National Commission for the Protection of Human Subjects. That's the legislative mandate that sets up the institutional review boards and the protection of human subjects, and it was the Public Health Service syphilis study that we just went through in this section. Thanks. Okay, so before we get into issues about planning public health programs, I wanted to make sure that I touched on issues about priorities in public health and setting objectives, because before you plan programs, you want to have an awareness of what are the major issues and challenges in public health, and you want to have an idea about what the objectives are for public health, so that you can make sure that your resources are targeting those problems that are of most concern to the population. So there are a couple of resources that we have for being able to identify priority public health issues. One thing is called CDC's Winnable Battles. So CDC has identified 6 areas that are of high public health importance and that have evidence-based interventions that can prevent or reduce these problems. And so they're considered high challenges, but the challenges are winnable. And they include healthcare-associated infections, HIV, motor vehicle injuries, obesity, nutrition, physical activity and food safety, teen pregnancy, and tobacco. Those are the winnable battles. So when you're thinking about programs that you want to implement, implementing a program in the area of one of these winnable battles makes a lot of sense, because these are important challenges that have evidence-based strategies. Another resource for identifying objectives for program planning are the Department of Health and Human Services major priority areas for health disparities. So when we're looking not just at what are the challenges affecting our whole population, but we're looking for where is it that certain subgroups still have not benefited from the health endeavors and health strategies that have gone out to the population. Where do we still have subgroups who are still at risk because we don't have equitable reach? These are also important ways to set objectives for program planning by focusing in on areas of health disparities or health inequities. And the 6 areas for health disparities, health inequities, are infant mortality, cancer screening and management, cardiovascular disease, diabetes, HIV/AIDS, and immunizations. Another resource for identifying objectives is to go to the Healthy People Initiative site for Department of Health and Human Services. So in addition to the Department of Health and Human Services identifying the major health disparities in the population, they have identified national public health objectives, and they've done it on a decade-wide basis every 10 years since 1980, and the initiative is called Healthy People. The goal of Healthy People is to increase life expectancy, but also the quality of years of life, and to eliminate health disparities by identifying a set of public health priorities that have corresponding objectives and benchmarks. And the purpose of using this whole framework of Healthy People is for health departments to be able to assess where they are, and over a 10-year period to be able to plan programs directed at these objectives, and then to monitor those programs to see whether they're having their impact on the public health priorities over time. So there's a website for Healthy People that provides a lot of detail about the Healthy People Initiative, and a quicker look about Healthy People 2020, which is our current initiative that we're in, is on this YouTube link that I've given you with Howard Koh talking about Healthy People 2020. So now I want to talk about planning, and I'm going to spend most of my time talking about public health planning, talking about the Precede-Proceed model, which is a major model that's used for public health initiatives, and I will touch on a couple of the other models that are used for planning, but this is used so widely in public health, I wanted to spend most of the time that I have for planning to talk through the issues about Precede-Proceed and to delineate what goes on in each of the phases. Precede-Proceed has 8 phases altogether, 4 for Precede and 4 for Proceed. In Precede, the phases are social diagnosis, epidemiologic diagnosis, educational and organizational diagnosis, and administrative and policy diagnosis. So what you're thinking of when you're thinking about the Precede part, the 4 phases in the Precede part, that component is gathering information from different components and different stakeholders in an environment in order to adequately identify the problem and all of the factors that are leading up to the problem. And that thorough understanding of a problem and its determinants will then lead into an intervention plan that is the Proceed part of this model, so the next stage of this model. So Precede has these 4 phases. Social diagnosis is a process of gaining information from the community about what it wants and what it needs in order to improve both community health and also the quality of life in the community. And at the end of this phase of the Precede model, you come up with an identified community health outcome that the community would like to have. So it's the goal for the program that's going to be developed. We want to have this kind of outcome, and that comes from the social diagnosis. In epidemiologic diagnosis, we're now bringing in much more of the evidence base to understand the evidence about that particular outcome that was chosen by the community. So it's identifying health behaviors, interpersonal factors, organizational factors, community factors, societal factors. Again, looking at all the different levels in the social ecological model to be able to identify which of those determinants are the major determinants of the outcome that was identified by the community in stage 1, the social diagnosis phase. So this is all the literature that provides the evidence about the major risk factors for that community identified outcome. And what's also important is to make sure that the risk factors are major risk factors. So when you're identifying risk factors in epidemiologic diagnosis, you might develop an entire list, but you want to delineate the major risk factors, the ones that have the most attributable risk for your particular outcome, and you want to identify malleable risk factors. So you don't want to identify a risk factor that can't be changed with intervention. And so the significant and malleable risk factors are what help you develop program objectives. The third phase is educational and organizational diagnosis. And what you're doing in this phase is identifying all of the predisposing, enabling, and reinforcing factors. So you're looking at when we've identified factors that we want to change from the previous phase, epidemiologic diagnosis, what are predisposing, enabling, and reinforcing factors that can either help us make those changes or get in the way of those changes. And the last phase in pre-seed is administrative and policy diagnosis. It's identifying and modifying administrative issues and policies in order to generate funding and other resources for the intervention. Now we're going to move to proceed. So the previous 4 phases from pre-seed have given us a good model of an outcome, the factors related to an outcome, what facilitates or gets in the way of us achieving that outcome, and what resources and funding are needed in order to implement a change. So proceed is now taking that information and instituting and sustaining the change, instituting, evaluating, sustaining the change. In proceed,
Dr. Allman?
Yes.
Dr. Allman, this is Heather. We seem to be stuck on the quick poll page. I don't know if we can maybe check. There we go. Great, thank you.
I am so sorry. Should I go back?
If someone could post just a comment in the questions whether or not that would be helpful, that would be great. Just briefly.
Just briefly, okay. So sorry. So these were the priority public health issues that we discussed, the CDC winnable battles and the DHHS major priorities for health disparities. This slide is showing about Healthy People, the Healthy People Initiative. There's information in the website about the Healthy People Initiative, which gives objectives, national health public health objectives, and benchmarks that can be used for local health departments to help them with planning and to monitor their progress on the objectives over a 10-year period. And then there is a link for a YouTube video from Dr. Ko on Healthy People 2020. These are the 4 phases of pre-seed. And I just finished talking about social diagnosis, epidemiologic diagnosis, educational and organizational diagnosis, and administrative and policy diagnosis. These 4 phases of pre-seed give us a community-identified health outcome, a set of major determinants of that health outcome, a set of factors that may facilitate or get in the way of changing the major determinants of the health outcome, and the funding and other resources that are needed to mount an effort directed at improving that community health outcome. And so now this is where I was, pre-seed component. I apologize, I am so sorry. Hopefully that caught everybody up. And we are now here on pre-seed, where we're taking the information from pre-seed and we're implementing and evaluating an intervention, a program. The phases here are implementation, which is when we're starting up and conducting the intervention. The next stage is process evaluation, which is research that will help to investigate whether the intervention is proceeding as planned and being able to adjust different intervention activities as needed in order to have the planned effect. Impact evaluation is investigating whether the intervention is changing the planned risk factors. And then outcome evaluation is seeing whether the intervention is not only changing the planned risk factors, but those changed risk factors are accruing over time to give us an outcome. So sometimes people get confused about process evaluation, impact evaluation, and outcome evaluation. So I'll give you an example of when you're doing a program. We'll give as an example a program that is identifying low-income women who have risk for cardiovascular disease. And the program wants to do a clinical evaluation of the low-income women and provide Medicaid-sponsored services to have appropriate standard of care clinical treatment for their cardiovascular disease risk. So if they have diabetes, they would get diabetes self-management activities, and their blood sugar and A1C would be monitored. If they have high blood pressure, they would get appropriate medication and monitoring, so on. So this program is going to provide to identify low-income women with cardiovascular disease risk, give them appropriate clinical services, and then give them appropriate lifestyle services such as counseling to improve diet and physical activity. A process evaluation of this program could look at fidelity issues, and fidelity has to do with, are activities happening as planned? So a fidelity process question would be, are all low-income women with cardiovascular disease risk, have they had an intake procedure, and have they had appropriate lab work to be able to identify their baseline status? And so you have a set of activities that should be happening as part of this program, and checking them off that they're happening is a fidelity process evaluation question. So are activities happening as planned? Another type of process evaluation could look at things like there could be a radio ad telling people in the community about the program, and there could be a flyer at the grocery store telling people about the program. And then you could evaluate which recruitment tool, radio or flyer, works the best. So you're investigating a recruitment process about the program. So those are examples of process evaluation. Impact evaluation for this program, if you're saying that diet and physical activity are risk factors for cardiovascular disease risk, you're looking to see whether the program activities are changing diet towards a healthier diet or increasing physical activity. That's an impact evaluation. You're seeing whether you've changed the risk factors. Outcome evaluation would look at whether, as those changes in diet and physical activity and compliance with medication and compliance with monitoring, self-monitoring and self-management, as those happened over time, would you accrue effects like reduced high blood pressure and reduced cardiovascular disease risk. So I hope that that little example helps with distinguishing those different types of evaluation, and I will check the questions to see if I need to talk a little bit more. I did want to send you to this resource on the precede-proceed model, so you have a link to a site that goes into more detail than I've been able to go into today. And this is also just a graphic from that resource that shows the 4 phases of precede are listed across the top. So that's identifying the problem, getting the data about the major determinants of the problem, being able to identify factors that either facilitate or get in the way of making a change, and looking at the resources and funding that would be needed in order to implement a program. At the bottom, you have the 4 phases of proceed, which are implementing the program, investigating processes like fidelity and different types of activities within the program, impact, which looks at whether the risk factors were changed, and then outcome, looking to see whether you've affected your community-identified health outcome. There are a couple of questions about is impact short-term and outcome long-term, and that is another way of looking at it. Impact is looking at what would be your proximal or short-term outcomes, what should change first because you're administering the program, and outcome is more of a long-term set of factors where when your risk factors are changed, then you should see health outcomes changing because of the risk factors having accrued, that change risk factor having accrued over time. Okay, so you can let me know if you have more questions about precede, proceed. I will look in the question box, but I'm going to move on to talking about another model that has been used in public health for planning, and it's the social marketing model. In social marketing, the principles of from business and finance about learning how to advertise and market products to audiences, those principles have been applied to the particular case of being able to market an intervention either to individuals, to at the interpersonal level, to small groups, to organizations, to communities, or to societies. And the goal of a social marketing campaign is to influence the consumers, who can be individuals, organizations, communities, to buy a behavior change. So we're not buying a product, we're buying a particular behavior change that's being marketed, or we're buying a health-related product or technology. And similar to a marketing campaign for a non-health product, a social marketing campaign is built around the 4 Ps. The 4 P's are product, price, place, and promotion. Product is the behavior, the program, or the technology that you're trying to market. Price is the cost to the consumer of adopting that behavior, program, or technology. Place is where the product is going to be available or promoted. And promotion is how to promote the first 3 P's through persuasive strategies. And social marketing campaigns have been going on over the past 20 years. You can see social marketing around dietary change, around increased physical activity, around reducing or ceasing tobacco use, reducing alcohol use, or reducing alcohol use to what would be considered mild to moderate use. And so using seat belts, getting immunized, social marketing has been used across a gamut of public health challenges and have been successful. And if you're interested in using this as a planning strategy, my suggestion would be to look at social marketing campaigns that have been successful for the particular health outcome that you're interested in, because there may be subtleties about how to develop the campaign that are related to particular health outcomes. And this slide lists some other planning models, just so that you're aware of other models that have been used in public health. And if you want to get more details about these particular models, I would refer you to common textbooks in public health that you probably have in your library to get more details about each of these models. So some of the other models that you may want to look up are the Assessment Protocol for Excellence in Public Health, the Multi-Level Approach to Community Health, Planned Approach to Community Health, and Mobilizing Action through Planning and Partnerships. All of these models that I've talked about, pre-seed, proceed, social marketing, and the 4 models on the previous page, have a lot of commonality, and these are the features that are in common across planning models. And so this is a good, these 7 steps are a good generic set of planning steps. Regardless of which model you're looking at, these are the core activities that would be engaged in a successful, you would engage in a successful planning effort. The first thing is community involvement and mobilization. The second is needs assessment at the community and organizational levels. So community involvement and mobilization is important because an accurate and comprehensive needs assessment would need the community to be involved. The community must have capacity to engage in planning, implementation, and evaluation. The community resources, community coalitions have to be mobilized in order to proceed with planning, implementation, evaluation. The needs assessment needs to occur at community and organizational levels. There needs to be a selection of specific target audiences. You want to develop specific, measurable, attainable, and time-bound objectives and their indicators so that the effort can be monitored over time to see if objectives are being met. And if objectives are not being met, then you have an opportunity to use that information to do mid-course corrections and either tweak your program or amplify your program in order to make sure that you're meeting objectives and indicators. You want to have action plan development and implementation, and then after your program is implemented, you evaluate program processes and outcomes so that you can engage in a continuous cycle of quality improvement. Once you have a program that you feel is achieving its effect as efficiently as possible and for as many people as possible, you then look at issues about institutionalization so that that program becomes sustainable. Okay, so I'm going to now do a review of this particular section with a couple of poll questions. Here's the first one. Okay, it looks like most of you have voted. So there's just people are kind of divided between social diagnosis and educational and organizational diagnosis. So let's talk about this a little bit to make sure that we understand the different phases. So the question was, in what phase of pre-seed do you identify predisposing, reinforcing, and enabling factors? And the correct answer would be educational and organizational diagnosis. Let's go through some of the key issues of each of these phases of pre-seed just so that we can distinguish that. In social diagnosis, what you're doing is a community process to identify a health outcome. In epidemiologic diagnosis, you are looking at the literature to identify all of the major determinants of that health outcome that was identified by the community. In educational and organizational diagnosis, you're looking at when you look at trying to change that determinant, what are all the predisposing, facilitating, impeding factors that could either help you make that change or get in the way of making a change of a major determinant. And then finally, in administrative and policy diagnosis, you're looking at funding and resources that are needed to implement the change. Does that help people see the differences between the phases, the 4 phases of pre-seed? Okay, thanks. So I'm going to do the next poll question, which has to do with the proceed phase of the pre-seed proceed model. Okay, it looks like most people have voted, and you've got the correct answer of impact evaluation. That's exactly right. Implementation is instituting a program, processes looking at issues like fidelity, how much of the activities, are the activities happening as planned, or different processes related to the activities of the program. Impact is looking at knowledge, attitudes, intentions, behaviors, and outcomes are looking at kind of your distal health outcomes that were initially identified as part of social diagnosis. Great work, everyone. Okay, so we're going to move on to talking in this section about program evaluation and talking about what it is and also some of the different methods that are used for program evaluation. So first of all, what is it? It's a systematic process that uses both qualitative and quantitative methods to answer questions about how big is the problem, what are the processes of delivering the program, what are the outcomes, and how efficiently are those outcomes met. It helps make sure that actions are not just occurring without us understanding whether they are having an impact on the public health problems that they are directed at. And it encourages the use of evidence in order to make decisions about programs and policies. And so evaluating whether a program has met its outcomes efficiently helps us with further decisions about whether that program should be more widely disseminated or whether we should go back and retool that program because it didn't have its intended effect. When we're looking at how big is the problem, which is the way to start off before we develop a program and before we design anything about how to act in order to meet a particular public health challenge, we need to know how big the problem is, and we need to measure how big that problem is over time once the program is implemented to see whether the magnitude of the problem is decreasing over time. In needs assessment, we're looking at how big is the problem, what are the consequences of the problem, and are subgroups of people or different locales differentially affected by the problem. So we're getting a picture of how big the problem is and variation by people or place. Some of the methods that are used for needs assessment include key informant interviews, a forum of community members, looking at agency records, looking at community health indicators and determinants of health from public data sets, or conducting your own community survey to get information about the needs in that community. For process evaluation, the purpose is to investigate the fidelity of the program and investigate the outputs, investigate the types of activities that are happening in the program. So the indicators are things like what program activities are delivered, who delivers them, when and where are they delivered, and the number of people served. Outcome evaluation is looking at the effect of the program on short-term outcomes, intermediate outcomes, and long-term outcomes. And examples of how those outcomes differ is that short-term outcomes are closest to what you would expect would change in behavior because you've implemented the program. So what would you see first are the short-term outcomes. As those short-term outcomes accrue over time, you see intermediate outcomes, and as intermediate outcomes accrue over time, you see the longer-term outcomes. So what you can measure first are the short-term outcomes, and then you need to have time pass for you to be able to measure the intermediate and the long-term outcomes. And examples of outcomes at these different stages, short-term would be things like, did the program increase knowledge, did it change attitudes and beliefs, or did it increase skills? Intermediate outcomes would be things like behavior change. So if you have successfully increased knowledge, changed beliefs, increased skills, you should then see over time that the behavior has then changed. And then finally, the behavior change as it accrues over time should result in decreased rates of disease, disability, death, or disparity. An efficiency evaluation looks at the cost-benefit of programs. So it compares the cost of the program to either its effects or to put a dollar sign onto the effects and say, for every dollar spent on this program, we gain X number of dollars in reduced disease, disability, death. So it's trying to not just look at, is the program effective, but given scarce economic resources, what is the most effective way, cost-effective way to get these same outcomes? Two programs could get us identical effects, but one could cost less than another. One could get those same effects for less resources, less financial resources. And so efficiency is not only looking at outcomes, but it's looking at how to produce those outcomes in the most cost-effective way. This is another evaluation metric that I think is very important for everyone to be aware of. It's the CDC framework for program evaluation in public health. And it has been used as a systematic method for evaluation that makes it very transparent how important it is for stakeholders to be involved in the entire process of planning, implementation, and evaluation. So unlike other evaluation methods, there are prescribed activities as part of the CDC framework for involving major stakeholders, not just at the end of a program, but through all phases of planning, implementing, and evaluating a program. And in addition to encouraging a very participatory approach to program evaluation, there's a focus that the findings don't just sit somewhere, but the findings get brought back into the cycle so that the findings are used in order to improve that program in the future. So there's a focus on sharing the lessons learned from the evaluation as broadly as possible so that those findings disseminate and are used by others. The steps of the CDC framework starts with engaging stakeholders, and stakeholders are identified and are involved in the development of the evaluation plan, the plan for the conduct of the evaluation, and the plan for the use of the evaluation results. Stakeholders can include people who are funding the program, who will be managing the program, leading the program, any sub-award grantees for the program, program partners, the evaluation team, anybody who is served by the program, affected by the program, or who may use the evaluation. So when you're thinking about stakeholders and wanting to engage them, you want to try and get as diverse a group as possible in order to have diverse perspectives represented. The second step is to describe the program. And this involves developing a logic model which will guide the evaluation. A logic model will include the inputs to the program, the activities of the program, and then a set of outcomes at different stages. Short-term outcomes are those that would be immediately following the intervention. Intermediate outcomes would be at a follow-up, and after a sustained period of program implementation, you would look for long-term outcomes. So this is just some more details about developing a logic model as part of this second stage. What you want to do is identify all of the resources that are available to conduct the program activities. Those are your inputs. Under activities, in that box, you're completing everything that program staff are doing to accomplish your program objectives. The outputs are the direct and immediate results of all program activities. And so they can include things like the number of materials that were produced, the number of services delivered, the number of people attending sessions. So that shows you the immediate result of an activity happening. And then outcomes are the intended effects of the program activities. Outcomes are the short-term, intermediate-term, long-term effects of when the activities are conducted. We should see these changes leading up to our overall health goal change. The third step is to focus the evaluation design. And in this stage, you are brainstorming with your stakeholder group about different evaluation questions that can be answered, and you want to come up with the questions that are the most important to answer for that particular program at that particular phase. And what's important about the questions is that based on whether this is a new program or an established program, different questions may be important. For example, when you're starting a new program, implementation fidelity questions are really important questions to ask, because you want to first make sure that if you've planned a program, that everybody who's part of delivering the program is able to mount that program with fidelity, that most of what is the part of the program is happening as planned. It doesn't really make sense to look at outcome questions if you're not sure that the activities are happening as planned, because if there are problems with fidelity, so for example, if you've trained staff but the staff are still not delivering the program as planned, you wouldn't expect to see changes in clients. So the first thing in a new program is implementation fidelity. Are the activities happening as planned? Once you're sure that the implementation fidelity is happening, then you can start looking at short-term outcome questions and long-term outcome questions later on. And so based on the stage of your program, different questions are more important to answer that will lead into the program improvements that are most needed for that stage. And the critical thing is that stakeholders should be involved in developing these evaluation questions for each stage of the program. In step 4, you're gathering credible evidence. And that means you're gathering information about the program and its effects. And whenever existing data can be used, you should do that so that you're not burdening members of the program, either the staff of the program or the recipients of the program, to do additional evaluation data collection activity if it's not needed. So you initially look to see, is there existing data that can be used? And wherever existing data doesn't is not workable for you to use, then you develop new evaluation tools as needed in order to evaluate outcomes. So for example, when you're doing an intervention where you're changing some of the risk factors for chronic diseases, you might have in clinical records BMI measurements, waist to hip ratio measurements, blood pressure measurements, blood sugar measurements, and you don't need to do a separate evaluation to get that data if that data already exists in clinical records. So you want to take advantage of data that you can use to evaluate your program that may already exist, and then just design evaluation tools for those constructs which aren't measured in the existing data collection scheme. For step 5, you're justifying your conclusions, and in this case, you're taking the data that you collected in stage 4, where you've gathered credible evidence, and you're analyzing that data using quantitative or qualitative methods to answer questions about implementation fidelity, program processes, and program outcomes. In step 6, you're ensuring the use and sharing lessons learned. And so once you've got your findings, as I said before, the findings don't just sit there. Part of this CDC framework is that the findings get discussed, used, disseminated in order to make sure that the findings have a life beyond this particular program. And so part of the work of this stage of ensuring use and sharing lessons learned is to have a systematic communication and dissemination plan for the evaluation. So you want to have internal strategies for communicating the findings. You want to have strategies for communicating with stakeholders. You want to have methods for disseminating the findings to programs and providers. You want to have strategies for disseminating the findings to the scientific community. And then you want to also tailor your dissemination for policyholders and for the public. A presentation that you give at a scientific conference or a paper that you provide to a scientific journal, you can't just copy that and hand that out to policy leaders and the public and expect them to see that as accessible information about evaluation findings. So a systematic plan would include that you have to disseminate your results to different audiences, and the methods may differ based on who's your audience. And your goal is to make sure that the evaluation information is accessible to as many audiences as possible. Okay, another model besides the CDC framework that's widely used as a way of evaluating a program is called the RE-AIM model. And its particular focus is on taking an effective program, a program that's been evaluated, found to be effective, and translating it into practice. So kind of taking it out of the research sphere and moving it into a practice environment. So the stages of this model are looking at the reach of the program. So how do I reach the targeted population? Looking at the effectiveness. How do I know my intervention is effective? Looking at adoption by a large number of diverse settings. So moving out from just one program, one catchment area, and looking at how organizational support is developed in order to deliver the intervention in a variety of settings. Implementation focuses on how do I ensure that the intervention is developed properly as it moves into these different settings. What's the best way to replicate an effective program so its effects don't decay as you move it, and disseminate it more broadly. And then finally, you're focused on maintenance through institutionalization or becoming part of organizational policies and practices. So these are things where you could take the activities in your program and convert them to Medicaid categories of services so that the services can be billed ultimately and it becomes a sustainable program over time. Okay, so I wanted to talk about dissemination and scaling up. I am going to take a minute to just check to see if there were any questions about this last section on evaluation before I move on to dissemination and scaling up. So just give me a minute. There's a great question. Thank you. Your questions have been fantastic, by the way. Thanks so much. There's a question about, is cost effectiveness the same as cost benefit? And it is not. The cost part is the same. In cost effectiveness, you're identifying the incremental cost of a program. So that's going to give you a dollar value. in order to implement this program, it costs $250 per person to implement the program. So the cost is always the same. But in cost effectiveness, you're saying for every $250, we save X number of lives. That's the effect. Cost effectiveness is for dollars spent. This is the health effect. For cost benefit, you take the number of lives saved and you put a dollar value onto that. So health economists have ways of looking at if you gain 3.7 years of life on average for everybody in the program, what does that come to in a dollar figure? So for every dollar we spend, we save these many dollars. That's cost benefit. It's when the outcome is not just a health outcome, but it's been monetized and translated into a dollar value. So I hope that answers the question about the difference between cost effectiveness and cost benefit. Let me check. There's a good question about REAIM. Is it useful after doing a successful pilot study? I would say anytime you're trying to have a program move into different settings, which might be after a pilot or might be after a more rigorous evaluation, REAIM is useful because you're looking at these issues of replication and trying to make sure that you can translate a program that's been effective in one setting and make sure that it retains its effectiveness as you move it across either different groups or different settings. So, great question. Thank you. Okay, I'm going to now talk about dissemination and scaling up because often what happens is people think about planning a program, implementing it, and evaluating it, and you found out that it works, and then you move on to something else. And these issues of dissemination and scale up are terribly important because of this issue of winnable battles. We have so many challenges where we have an evidence-based strategy that we know will prevent that problem. But our issue is not that we don't know what to do. The issue is translating what we know to action. And so there's a whole set of strategies that help us understand, once we have the knowledge about what works to solve a problem, how do we make sure that that information is widely disseminated and that we can take a small successful program and scale it up so it really does become something that can affect population health. So I'm going to end our webinar today talking about issues about dissemination and scale up because those are areas where we really need to move so much in public health, not just be content with one program that's evaluated and is working well, but to think about the bigger picture and think about how do we take our knowledge and our successes and really make sure that that knowledge is available to everyone in order to improve health for all. So just some definitions to start off with. Dissemination is when you're distributing information and materials about an intervention to a specific public health or clinical practice audience. And so some examples of that would be quality improvement cycles where on a regular basis you incorporate new evidence-based strategies into practice. So health departments might review evidence on an annual basis and then change their practice procedures at all of their health department clinics based on the newest evidence. So the standard of care can switch based on quality improvement cycles of review. Another example of dissemination is when you provide decision support tools to improve the uptake of an intervention. So you might, as a provider, be talking with a patient about the importance of physical activity. When you give them decision support tools to help them work through the pros and cons about having more physical activity, increasing their physical activity. That's a way to disseminate that information and have more of an effect on the intended audience. So dissemination is making sure that information reaches the people that it's needed to reach. Scaling up means you're increasing the impact of the program while keeping the quality the same. And that's really the trick, because a lot of times what happens when you scale up is a program effect seems to decay because there's not adequate fidelity as you replicate. And as more and more people start doing the program, you get less of an effect because parts of the program get lost as it moves from setting to setting. And so scaling up prevents that effect from happening. You want to increase the impact. You want to have a wider area, more organizations doing the program, but you want to keep the quality exactly the same as when it was just happening in one site. So there are 4 categories of scale up. Scale up can happen in a quantitative way, which just means increasing the number of clients that are reached by a program. So you might scale up a program because you've added a new target audience. You were originally targeting 12 to 18-year-olds, and now you're going to target 18 to 25-year-olds. So you can increase the numbers by changing who your target audience is. You can move from one community into another, so you can expand into a new geographic area, and that will give you an increased number of clients. You can adopt and use programs and materials by others, and the adoption of novel materials can increase the number of clients coming in. Diffusion of innovation theory is a really helpful theory of change when you're trying to increase the number of clients reached, because there are strategies about looking at who are early adopters and who are later adopters, and how do you get a successful intervention to be diffused among all parts of a population. So for increasing numbers, diffusion of innovations is something that can help you as a theoretical framework. Another way of scaling up is expanding the program breadth. So you might want to take your focus and say, how could I make this focus for my program even broader? And that can be by increasing the number and type of areas that are addressed by a program. You might have a program that is addressing physical activity, and then you scale it up by including diet and tobacco cessation. So that's a case where functionally you've scaled up because you've made the program broader than the way it was originally. Political is a way of scaling up where you have the ability to address national level barriers to services. So in political scale up, you're advocating for efficient processes, clear policies and guidelines, and standardizing materials for education and training. And the final category of scale up is organizational, and that's improving either your own or another organization's ability to continue to support an initiative, and that's by diversifying or stabilizing the funding base. So things like taking the activities and putting them into a scheme so that they can be billed as supplemental services through Medicaid. That would be a way of an organizational scale up that stabilizes your funding base. You can increase the use of effective financial schemes, develop strategic alliances to increase resources. So for example, if your program can ally with a community garden, that would be a strategic alliance where you then have more resources for your clients about healthy foods and physical activity. building technical and management capacity in order to sustain the efforts. So having people on staff who can do economic evaluations and be able to do cost-benefit analysis, people who have the ability to do policy development, to have policies that support what's going on in the program. All of those are organizational strategies that can help with scale-up. And then there are some strategies that are useful for ensuring program sustainability. And these include building community and organizational capacity in management, advocacy, fundraising, and training, utilizing simple, user-friendly, accessible materials and tools, involving community members in every step of the program so that you've got community support, community capacity, community mobilization to sustain this program over time, develop, implement, and institutionalize cost recovery mechanisms, develop, implement, and institutionalize quality assurance and self-assessment tools, build on pre-existing structures whenever you can, develop program leaders and program champions, and encourage cross-community learning. So all of these are strategies that have been shown to improve and support program sustainability, and I'm sure that there are many more things that are being found out almost on a daily basis because this is a newer area of public health research, and so a lot of new information is coming out about how to effectively sustain programs. Particularly with the Affordable Care Act, there are new mechanisms now to sustain programs that didn't exist before. I am going to let us review this last section by a final poll question. Okay, most people have voted and have gotten the correct answer, which is scale up. So a program that adds new target audiences or expands into new geographic areas is an example of scaling up. I'm going to take a minute to check if there are any questions to answer, and we have about 10 minutes left, so if you've got a question, please post it. There's a question about being able to view the presentations later, and I can answer part of that right now, and then Heather may want to add some more in a bit. The PowerPoint that I used for this webinar is posted right now. on the site. And then in several days, the recording of this webinar, which is the PowerPoint and all of the conversation that we've had since 1 o'clock today, all of that, the recorded webinar will be posted in several days on the site. Heather, did you want to add anything else?
No, that's accurate. The information or the link to both the slides and where the webinar will be posted is still in the chat box. So if you open up your chat box, you will see the link there. And the difference will be on the site currently, if the webinar is available, view webinar as the button link there versus register for webinar. So that's how you will know there are 2 posted now. The goal is to have 2 others posted by the end of the week, and this one posted as quickly as possible.
And the other thing is that I will, I've been going through the questions as I've been doing the presentation, trying to answer as many as I could, but I will, after the webinar is over, go through all of the questions and answer all of them so that that can be posted for folks. There's a question that relates to the evaluation part of the webinar, asking about what are quantitative methods used in program evaluation. So when people are doing quantitative methods, they're collecting quantitative data. That could be through surveys, interviews, observations, abstracting information from records, pulling lab results, and the quantitative information that is collected is then analyzed using biostatistical methods to be able to determine whether a program has had a significant effect. So you either compare pre and post. Is this measure significantly better after the program? Or you can have a comparison group or a control group where you're saying, is this result in the intervention group significantly better than the comparison or control? Qualitative methods in program evaluation would be things like focus groups, semi-structured interviews, photo, voice, other qualitative methods that give you richness and detail about the program, but do not give you the same validity as the quantitative methods. So Anthony, if you could let me know if that answered your question or if you'd like me to speak a little bit more about it. There was a question about could I speculate on how intricate the test is going to be in regard to the theories of change? And I would say that the study guide is a good way to become familiar with the theories, and it's important to know the basic premise of each theory, and it's important to know the major constructs of the theories and be able to distinguish between them. So to understand how does social influence differ from social cognitive, to be able to, in a general way, be able to identify the premise, the major constructs of each theory and distinguish between them, I think would be an important way to study. There's a question about the psychology concept that was mentioned at the very beginning of the webinar. In the first part, it was referring to future planning, and that's called future time perspective. And it has to do with the endorsement of being able to see your life and who you will be, the opportunities you'll have farther into the future. More disadvantaged populations are less likely to be able to envision themselves in the future and make decisions based more on their immediate time circumstance, as opposed to, if I do this now, it will be better for me in the future. I'll have these benefits in the future. So I hope that answered Matthew's question about future time perspective. I think I've got all of the questions. Heather, I want to check with you. Will there be a place for me to post the launch questions with their answers?
We can have Elliot post a link up there as well. It will probably be posted right next to the slide.
Okay,
file. Yeah, sure.
Well, I want to thank everyone for participating, and I really have loved so much the questions and comments during the presentation. It's helped me so much that you've asked those questions that have probed, made us probe a little bit more and go into more detail. And I wish all of you success with the exam.
Thank you very much, Dr. Ulmer. Quickly, for those of you who want to jump into the chat box one more time, I posted the link again. And when the webinars are available for viewing, the link on that page will change from register to view webinar. And you'll see that there are 2 posted there now. If you have any other questions, you can. Thank you very much for your time this afternoon, and thank you, Dr. Ulmer.
My pleasure.
Bye-bye.